When looking at renal disease in pregnancy, we will be looking at the physiological changes in pregnancy. The main focus of this talk will be acute kidney injury, with an insert looking at preeclampsia with acute kidney injury, and then chronic kidney disease. The renal physiology changes during pregnancy. As we know, the overall blood volume increases, which means that the renal plasma flow increases progressively as well, up to 80% above the non-pregnant levels in the second trimester. It then falls to about 50% above non-pregnant levels in the third trimester. This is presumed that the third trimester decline is in part related to the compression of the intra-abdominal large vessels by the gravid uterus. The increase in renal plasma flow in pregnancy is the consequence of renal vasodilatation with profound reductions in renal afferent and efferent arteriolar resistance. Renal hyperperfusion therefore determines the renal hyperfiltration that is seen in pregnancy. This results in increased urinary output as well as frequency. There is also an increase in glomerular filtration rate of as much as 25% that is seen as early as 3 to 4 weeks post-conception. At about 16 weeks gestation, the glomerular filtration rate is 55% above the non-pregnant levels. Consequently, the creatinine clearance increases as well, from a non-pregnant normal range of 100 to 180 milliliters per minute to 150 to 200 milliliters per minute. The serum, urea, and creatinine therefore decline. Values that are considered normal in the non-pregnant state may be abnormal during pregnancy. A urea value of 5 and a creatinine value of 80 may indicate pre-existing renal disease or pregnancy-induced complications. The excretion of protein in pregnancy is also increased. Therefore, a baseline is important, especially in abnormal cases. The protein urea that is normal can be as much as 300 milligrams per 24 hours. While we're all in lockdown, these beautiful creatures are out and about roaming the streets of Cape Town. The importance of acute kidney injury is that although it is rare, it still holds increased maternal as well as fetal mortality and morbidity in low-income countries. Outside of pregnancy, acute kidney injury holds risk for chronic kidney disease development, especially in low to middle income countries when compared to higher income countries. Pregnancy-related acute kidney injury and its relation to chronic kidney disease in low to middle income countries are still unknown. Pregnancy is a hyperinflammatory state, and due to the changes to the vascular endothelium as well as its prothrombotic nature, pregnant patients are more inclined to developing acute tubular necrosis, and they are more prone to progress from a state of temporary acute tubular necrosis to bilateral renal cortical necrosis with resultant permanent renal impairment. This is more likely to occur if the pre-renal insult coexists with preeclampsia. The leading cause being hypertensive-related disorders, and this is a worldwide phenomenon. A large number of these cases, however, are preventable. It also holds an increased risk for the development of cardiovascular disease, chronic kidney disease, as well as end-stage renal failure. The magnitude of the problem is that the global incidence of pregnancy-related acute kidney injury has declined. This is largely due to improvements in reproductive health services. In low to middle income countries, it does contribute greatly to mortality as well as morbidity, including the need for dialysis. Therefore, early recognition and management is key in improving outcomes. Approximately 13.3 million acute kidney injury cases occur worldwide per annum, and 85% of these cases are found in low to middle income countries. When compared to higher income countries, low middle income countries had a greater number of acute kidney injury cases that were pregnancy related, and hypertensive related disorders were found to be the main cause. The incidence in high income countries have also declined with improvement in abortion services as well as general clinical obstetric care. There is now, however, a new increase being seen, possibly due to advanced maternal age, as well as the occurrence of obesity, diabetes, and hypertension. The incidence in low middle income countries in early pregnancy is associated with septic abortion and later on in pregnancy due to hypertension, abruptio, hypovolemic shock, and sepsis. The definition of acute kidney injury is the rapid, sudden deterioration in renal function with the accumulation of waste products such as urea and creatinine with possible associated oliguria. Of note that in pregnancy, this definition is hard due to the physiological changes that affect the urinary tract. The usual formulas that are used outside of pregnancy are often inaccurate. The gold standard is therefore a 24-hour urine creatinine clearance. The significance of these limitations is that what may be normal outside of pregnancy may be abnormal in pregnancy. The KDIGO, or Kidney Disease Improving Global Outcomes, categories are used to define acute kidney injury and to stage them by looking at the change in creatinine levels as well as urine output. Stage 1 is an increase of 1.5 to 1.9 times the baseline creatinine value, and oliguria by definition being less than 0.5 milliliters per kilogram per hour, lasting 6 to 12 hours. Stage 2 is a 2 to 2.9% increase of creatinine from baseline, and oliguria lasting longer than 12 hours. Stage 3 is a creatinine increase of 3 times more than that of the baseline, and oliguria lasting longer than 24 hours, or anuria being present for more than 12 hours. Ideally, baseline creatinine values are important as it allows us to look at the trend, which is important in making the diagnosis of acute kidney injury. An individual creatinine value should, however, be interpreted with caution, bearing in mind the possibility of the presence of chronic kidney disease. Oliguria with a rising creatinine value is an important warning sign. However, in the presence of oliguria, other secondary causes such as preeclampsia needs to be excluded. When anuria is present, it is an emergency and may be indicative of the development of bilateral renal cortical necrosis. The etiology can be either a newly diagnosed condition in a previously healthy patient or a known chronic renal patient now with an acute exacerbation or deterioration in function, or new renal disease that is only revealing itself now that the patient is pregnant. In terms of causes, it's also subdivided into prerenal, renal, and postrenal causes. The prerenal causes are often due to hemorrhage due to abruptio placenta or placenta previa, or sepsis due to chorioamnionitis and pyelonephritis. These conditions compromise the renal perfusion, which may lead to acute tubular necrosis and ultimately renal damage. The renal causes are due to preeclampsia, HELLP syndrome, acute fatty liver pregnancy, or thrombotic thrombocytopenic purpura. The postrenal causes are usually of an obstructive nature, such as calculi or the presence of a tumor. However, ureteric injury also needs to be borne in mind. The phases of pre-renal injury are divided into three. We start with the early phase. This consists of moderate renal ischemia. It is reversible if the perfusion is restored timeously. It is then followed by acute tubular injury. This occurs with prolonged hypoperfusion. It is still reversible as limited cells are usually affected. Then lastly, we have a renal cortical necrosis. This is when severe ischemia with necrosis of the glomeruli occur. It is irreversible, but because it occurs in patches, resolution is possible. The diagnosis is made by looking at history, examination with sideroom investigations, as well as special investigations. When focusing on the history, one's aim is to exclude any underlying secondary causes. Examination looks at blood pressure, protein, as well as urine output. Special investigations consist of baseline bloods, sending off the urine for microscopy and culture, as well as the 24-hour urine protein or protein creatinine ratio. A renal ultrasound may be helpful in excluding an obstruction and confirming the diagnosis of chronic kidney disease. Renal biopsies are not routinely done in patients with acute kidney injury in pregnancy. They are usually reserved for when the anticipated diagnosis has definitive treatment or when it occurs early in pregnancy, which may aid in deciding whether or not to prolong a pregnancy. The risk is bleeding, and therefore it is reserved to be done in the postpartum period. Ultimately, preeclampsia is common, but other pathologies that may present in a similar manner also need to be excluded. Management, by and large, consists of supportive care, with strict fluid management as well as electrolyte correction. If patients do not respond, they need to be referred to a higher level of care. Drugs that are nephrotoxic, such as aminoglycosides and nonsteroidals, need to be discontinued, and drugs that are excreted by the kidney needs to have a renal adjusted dosages. A loading dose of magnesium sulfate, however, is safe. Fluid management is very crucial to maintain renal perfusion with an adequate blood pressure. This prevents further damage. However, caution needs to be taken with the oliguric patient, as excessive fluid transfusion may cause pulmonary edema. A central venous pressure monitor may be helpful in these situations. Acute tubular necrosis, where there's an increasing in urea and creatinine with oliguria, needs fluid restriction and strict electrolyte monitoring. The input is therefore the output plus 500 milliliters of fluid. Renal replacement therapy is rarely needed as most respond to supportive care. If not, then they may qualify for dialysis. When needed, it is mostly done in the postpartum period. Indications for dialysis are volume overload, as well as refractory hyperkalemia or refractory metabolic acidosis, as well as in patients with severe symptoms such as uremic encephalopathy. A South African study by Drakely et al. In 2002 showed that 10% of patients required dialysis, but in India as much as 50% did. In this study, women with severe preeclampsia and renal impairment, 10% required temporary dialysis, all with hemorrhage due to abruptio placenta or HELLP syndrome. When chronic kidney disease is present, dialysis may be considered when placental perfusion must be maintained so as to prolong pregnancy to a critical gestation. The basic principles are to treat the underlying cause and do so as soon as possible so as to prevent progressive damage. If the patient is still pregnant, to then time the delivery, especially if it will aid clinical improvement. These are just short inserts of cakes that I make. I bake thrice a year, given many family functions that I end up missing. So we've got a unicorn cake for my daughter. My son is obsessed with the Triassic and Jurassic period, so he loves dinosaurs. And then which mother would not love the sugar rush of a Candyland cake made for my youngest? So the outcomes. By far and large, there is reversal in most patients in the higher income countries. But this does depend on what the underlying cause is. There's an increased risk of chronic kidney disease in patients with thrombotic microangiopathies, as well as patients requiring dialysis and renal replacement treatment. For preeclamptic patients, we should allow 6 months' time for resolution of their proteinuria. If this persists, they need to be referred to nephrology. Those patients who survive the acute illness, function usually returns slowly over a period of 6 to 24 months. Long-term renal function, however, remains uncertain because the hyperfiltration through the remnant glomeruli may lead to progressive decline in renal function. The rate of recovery decreases the more severe the stage of acute kidney injury is. The risk for preeclampsia in subsequent pregnancies increases fourfold despite complete resolution. Therefore, we need to flag these patients for high-risk obstetric care in future pregnancies. Acute kidney injury in preeclampsia. Preeclampsia is a major cause of renal dysfunction in pregnancy, as it results in the development of glomerular endotheliosis. Preeclamptic patients usually have a mild reduction in glomerular filtration rate, but when they are complicated by circumstances such as an abruptio or the development of HELLP syndrome, then they may progress to acute kidney injury and cortical necrosis. They therefore require meticulous fluid management so as to avoid the development of pulmonary edema. The ultimate treatment is to prevent further deterioration, which is why delivery is so important. A South African study done by Conte Ramsden in 2019 showed the following. Pregnancy-related acute kidney injury complicated 15% of preeclamptic patients. Half of these were severe stages, with an increased rate of maternal as well as perinatal mortality. 2/3 recovered in the postpartum period, but long-term renal effects are still unknown. Acute kidney injury in preeclamptic patients, regardless of stage, has an increased risk of developing eclampsia, intracerebral hemorrhage, and increased ICU admissions, as well as increased rate of mortality and intrauterine fetal deaths, which increase as the severity of the acute kidney injury increases, when compared to preeclamptics who do not suffer acute kidney injury insult. Chronic renal disease in itself is a broad topic, but we will briefly touch on the following factors. There are 4 factors that determine the outcome in chronic kidney disease. It depends on what type of chronic kidney disease you have, whether or not there is associated hypertension, what the baseline serum creatinine value is, as well as the degree of proteinuria. Women with mild renal disease who become pregnant have only a slight increased risk of long-term damage to the kidneys due to pregnancy compared to women with mild renal disease who have never been pregnant before. We are nearly done. So in summary, acute kidney injury is rare but holds increased mortality and morbidity. There's an increased incidence of obesity, hypertension, and diabetes, which is exacerbating the problem. It may affect healthy people and those known with chronic kidney disease. The renal physiology changes in pregnancy. What is deemed normal outside of pregnancy may be abnormal during pregnancy. The definition of acute kidney injury in pregnancy is challenging. The causes are subdivided into prerenal, renal, and postrenal causes. It is most commonly associated with hypertension, sepsis, or hemorrhage. The treatment is to focus on the underlying cause and strict fluid management to prevent further damage. Dialysis is reserved for refractory cases. Most patients recover completely. However, the long-term implications of acute kidney injury in pregnancy are still unknown. I would like to thank Professor Hall for taking time out of his busy schedule to assist me in preparing this talk.
Pierce the first skull, be the difference. Together we can.